Hello and welcome again to the ORTHO REAL podcast. I am Dr. Matt Barber, and we are excited to be joined today by Dr. Andrew Wickline from New York. Dr. Wickline is actually the highest volume joint replacement surgeon in the state of New York. Has a practice that is extremely innovative, driven by data and results, and we're excited to talk to him today. Dr. Wickline, welcome.
Thank you very much for having me, Matt. I see you on LinkedIn all the time. You always have interesting stuff to say, so I'm happy to be here.
Well, thanks so much for joining us. I know you are a fellow of the Cleveland Clinic. Tell us about your training and your experience and how you came to be the superstar that you are now.
Well, first I have to thank my I went to Union College in Albany Med. We a 7-year medical program. I stayed there for residency, and it was a great residency. We did a lot of surgery. There was opportunity to take the extra call, and these days that's not, you can't work more than 80 hours. But if you really want to have great skills, you got to be there. You got to be doing the work. And I was fortunate because I was able to. I was on call the senior, fourth and fifth level resident. Sometimes, every night. It doesn't mean you're up all night. It means that you're available, right? And so I got to do lots of surgery with many different amazing mentors in Albany, and then Professor Borden and Victor Krebs and the rest of the crew at Cleveland Clinic. They did a great job showing me a kind of a different way to look at things from a very large system. And Les was really and he was an amazing surgeon. He was no nonsense, no frills, and could look at a joint and know exactly what the issues were. And he and the rest of the Cleveland Clinic mentors were really instrumental in showing me how to do things a little different. Albany was kind of New York City based, and Cleveland Clinic, and a lot of the guys there have been trained out of Tufts, so it was kind of Boston based. So it was like Boston, it was like the Yankees versus the Red Sox in some ways. So very, very helpful to have two different perspectives.
Dr. Borden was a good friend of my professional mentor, Dr. Headley, and I've met him as well. They did some combined meetings and fellow reunions together. Just an incredibly bright guy and a real gentleman. Great to be around. So over the last couple of years, you have gotten a lot of exposure around some of your publications in the Journal of Orthopedic Experience and Innovation for knee and hip replacement. And I think we could drill down on a lot of different parts of that. But tell me what you can about your therapy-free total knee replacement.
So, as many people heard in a previous podcast, the patient is the customer, right? And sometimes we forget that. And you have to ask the patient every day, and that they're in there for follow-up. Okay, how am I doing? How's my staff doing? Do you like my team? Because the team wants the feedback too. You're asking them, a lot of them, so they want to hear, that your patients are doing well and reached out. And, a lot of times patients will remember certain team members by name and ask me to talk to them. So it's a great way for team building, right? But also it's a great way to, and you tell them, listen, I got big shoulders. You got to tell me, you tell me the good things or what are the bad things? Is my phone, is it hard to call into my office? You kind of get the picture. In any event, the one thing that patients always told me at way back, at the 3-month follow-up, when the patient's finally happy with the knee at that time, they would say, Dr. Wickline, I love my new knee, but I really don't want you to fix the other one because the therapy was so painful. I don't really ever want to do that again. It was a really strenuous session, and taking pain pills all the time, and if you can do my other knee if I don't have to do therapy. And so there were a number of therapists in our area, some more aggressive than others, and I always thought that aggressive was the right way to be. But then I looked at the patients who went up north, up to the Adirondacks, and they didn't have easy access to therapy, and they just said, Wickline, show me 4 or 5 extra exercises that I can do that I'll do them for you, but I guess I can't get to a therapist. If you show me, this list of 20 that the therapist gave me is too many, dumb it down for me. And so that's what I did. I created, 4 simple exercises. You do it every single hour while you're awake, ideally. I give them a check boxes. And it's essentially like CPM once an hour. Bend and straighten your knee, do some ankle pumps, do a very short walk. Those are the things that are important. Get the motion, control the swelling. Just like, when we have ankle fractures, if you don't operate on that right away, what do you got to do? You got to wait for a week for the fracture pushes to go away, right? So exactly the same for total knee. Why are we torturing that tissue, which we've already tortured with the surgery, by asking them to do sit-to stands, squats, and lunges, and can you walk a quarter mile, a week post-op? That really is a mistake on that tissue. The tissue's traumatized enough. So when I looked at those patients, and I looked at the patients who were here in town going to my aggressive inpatient rehab at the time, I had doubled the manipulation rate for those inpatient rehab patients compared to patients up north. And I had more narcotic use in those patients. And it became very clear what the answer was. It would be aggressive therapy is a mistake. And so 7 years ago, I started embarking on this. At the time, everyone made fun of me, but as we said previously in another show, at AUKUS, from the podium, aggressive therapy may not be the answer. So anyone who's listening, at least think that. I get it. It goes against convention, but I had a guy drive up for me for my cash pay program for 8 hours to come to my facility in Utica, New York, because we offer the lowest cost and no therapy. And he's 8 days post-op, has 115 degrees of range of motion, never saw a therapist, and hasn't taken a single pain pill. So that's pretty impressive.
That's very impressive, and you've got a lot of great thoughts around that. Do you consider that then to be, it's certainly a different direction for that therapy? Is it, instead of therapy free, is it self-directed therapy? Or how do you consider it?
I think it's a more fair term. Just like at one point I did the most volume in New York. I don't want to do the most volume. My wife has had some medical issues, and you have to reassess, right? And my initial term was therapy-free total knee, meaning that you don't have to go to outpatient therapy. And currently with coronavirus, of course, this patient who drove up to see me, he loved that. There's 18 less potential exposure risks, going to a facility to work with someone. Tell me again the question again. I want to make sure I answer it first.
No, I think you did. I think it's do you consider that self-directed therapy? Because it sounds like you've really given patients a tool.
People in the market. Yeah, lots of people in the market that are offering to do that. But the reality is, if you teach them well, most patients don't need, as in my study, right, 86 to 85% of my patients use no physical therapy through 90 days post-op, with an average range of motion of 190 degrees at 3 weeks. So, and I'm working on getting that better, right, educating better. But you're right, it's self-directed. And for those patients who are failing, I absolutely use my therapy colleagues. I'm not saying that no therapy, I'm just saying change when you intervene with therapy.
So, I think that sparks a lot of fascinating questions for me about this, because, as you say, certainly I've got friends that are therapists and some that are listening to this that are like, what? I mean, this is very...
my therapist and my poor therapist this time, I brought them all into a meeting to my office and said, listen, this is where I'm going with this. I know that's not what everyone wants to hear. But, I think this is the right answer. And, there were a lot of people angry with me. I think initially, 5 years ago, I lost some business, but the outcomes were so much better. That business came back because word of mouth, patients go where they can get better quicker and have less pain and have less cost. But, none of my therapists have closed their office, right? Mm-hmm. So, ultimately, there was different work for them to do. And, at 6 weeks, some of those patients need therapy. Sometimes they're 3 weeks in therapy. And you see in a study, 15% of those patients did need therapy to get there. So it's just right sizing the amount of therapy.
That's a great way to think about it, and I think that's pushed me to at least 3 more questions here about this. So, one, for patients who may be thinking about a knee replacement that maybe don't have the type of background and understanding that you do in this space, why would I want to do this? My neighbor went to therapy. Everybody I know that's had a knee replacement has gone to outpatient physical therapy. Why would I want to consider that?
Well, I guess first I would say, then ask 5 friends who had a total knee and went to therapy if they liked it, number one. And then the therapists don't. Like, I have 2 therapists that work with me now. They help me with I do 1 visit pre-op. The therapist meets with them on my ASC or at the hospital post-op, verifying that the patient can do the self-directed exercises. And those therapists, the one therapist helped me do the hip study. She is a doctor of physical therapy, and she's taken a lot of flack from her colleagues for helping me do that study. But she sees the difference. When you want to know when you go to work every day that you're not hurting people and that you're actually helping them get better. And so she's very pleased to kind of see patients on a different aspect and rescue those patients who aren't following and aren't on track. But she views now and totally sees that the aggressive therapy isn't the right way to go. So, I do have therapists, colleagues, and patients who have their own kids are therapists who are worried. And now those therapists, I just had one from Colorado call me and said, I didn't believe, I didn't think this was a good idea, but my mom was so convinced by you. But I'm shocked at how quickly she recovered, way different than what we do in our office. And we are now changing the way we do the therapy in our office to a less aggressive, stay away from strength. I mean, let me ask you a question, Matt. When you've had those occasional patients who've fallen around 3 weeks post-op and it's split open their incision, and you have to emergently bring them back to the operating room to clean that up, what's the tissue like? It's terrible, right?
Yeah.
It's like sewing Jello together. I mean, the sutures don't want to hold, and that's exactly the time where patients are finally getting some motion when the standard model, in the textbook says it's time to start strengthening, right when the tissue is weak. And, doing sit-to-stands, and, when you do a sit-to-stand without arms, in a seated position, that's a lot of torque going through that extensor rectum abdomen that's repaired, up to 8 times your body weight in some studies. And, that's where we were seeing injuries. We presented that at World Ortho Conference that, by going away from formal therapy, we had 8% reduction in emergency office phone calls from, quote unquote, something happened in therapy. Because they're just being too aggressive.
You're blowing my mind here. I mean, great thoughts and really some, back to basic science about tissue healing and even how we used to think about tendon repairs and things like that of when those are weakest. And you're exactly right. You, I think, answered a little bit of my second question in there, but who does need therapy or who does need formal therapy? Are you rescuing the ones that are not progressing, or how do you do that?
So a couple things. Number one, the number one worst patient in my practice is a 58-year-old male. These patients are two things. I'm not sure if their pain level is different from the previous generation. Now, I'm pretty close to that, so I'm not saying anything that I'm not saying about myself. My wife says I'm a baby. But in my practice, those patients have the toughest time. And what I really think, at one point I thought, well, it's just it's that generation. I heard that at a meeting, but now I'm not so sure. I think it's actually mentally, in the current world that we live in, you're kind of at that age. You're kind of at that. You're at the peak of whatever job you're doing, right? I'm the expert. I'm a electrician. I'm a master electrician at 58 years old, and I know best. And and it's just the way society is. Men kind of have that. Whereas I think women are where society is, as you grow up as a woman sometimes, I think women are more willing to follow directions. And I mean, I always ask this to my patients, if you're a couple, if the wife buys the lawnmower and the man buys the lawnmower, husband buys the lawnmower, who's going to read the instruction book when they put the lawnmower together? The wife is, every single time. Not the man. The man thinks, oh, I know better. I can put it together. And he's got 6 parts left over. And he has to go back to the manual finally. And, it's the same little age-old thing about directions. Who asks for directions, the man or the woman, right? The woman's smart. She gets it done. We're not so bright sometimes. So I think that's really the answer. So these guys think that, the bending and the straightening hurts. So I'll do the 4th exercise, which is a walk. This one says to walk. So I'll walk all over. I'll show him, and that's an easy exercise, the walking. It doesn't hurt as much. But what they do is create more swelling. Fluid doesn't compress. And so now they get even further behind in the range of motion. So the number one culprit, I would say, is that I watch out for is the 58-year-old male. Every single patient gets the same soapbox talk that I'm giving you right now about what they're going to do wrong and why they must resist the urge to not follow the instruction book, which is the book that I give every patient. I just had a 53-year-old male nurse. He did his first knee, and at day 5, how you doing? I'm coming along and I'm walking all over. I said, uh-oh. Send me some pictures of your range of motion. He was 75 degrees. I want 90 at least every single time, every hour to do this exercise. I want to reach 90. And so I had to send him to therapy. But, again, I checked in at that day 5. Are you at 90? Send me a picture. Nope, not at 90. So he went to therapy. When I did his second knee 4 weeks later, he followed the book. He didn't walk all over. The swelling was less. He was able to achieve 90 every single time. Took less pain pills, had an easier recovery. So I think that's the number one patient. Number 2 are the patients that have more anxiety and or fibromyalgia. I think those patients are, can be a challenge and they need extra. They need they really need therapy as the mental exercise to know that they're on track. They need to hear that more. So I think those two groups are the go-tos. Obviously, if you have 15 allergies, that's a patient that has a hypersensitivity to medication. So I think those patients are potential risk. I guess a long answer to your question.
No, I think that's brilliant. It absolutely feels like you're looking into my practice or that of any other joint replacement surgeon in the country. I think those thoughts are spot on. So my last one, those being a little more patient and therapist directed, if we're turning this back to surgeons, do you do anything different technically in the OR for those patients if you know they're not going to have formal therapy? Do you balance the knee, quote unquote, a little more loose or try to, do anything different to enhance range of motion after surgery?
I do not. I think, I have a lot of computer navigation experience. I did it from 2004 to 2020. And I have now gone away from that because I've got 16 years of experience with x-rays that look perfect every single time. And, of course, have some patients that are unhappy. And the unhappy knees are the knees that are not, they're not, they need to be, I don't want to say tight, but they need to have minimal excess play. And so I think that is the most important factor in a happy recovery, a happy knee is a knee that, easily flexes and extends, during surgery, but there should not be tons of excess medial and lateral, opening. I test every knee before surgery. I love it when a patient has a normal knee on the opposite side. I try to match a normal knee on the other side. But no, I'm not changing my technique to get this easy range of motion. Easy range of motion just comes because it's 5 minutes an hour rather than a 90-minute session that makes the knee big and swollen. So, in fact, I do a standard medial parapatellar orthotomy. I'll make a bigger incision if I need to. When people come out to see me and they see the results, they think I've got some mini incision. I tried all those things. I didn't really find a huge difference in my practice. So I like a normal standard incision that can be extensile if necessary. That way I know the parts are where they belong. But I will tell you that, this year I have have moved to a kinematic alignment and trying to match that anatomic femur, make the femur I put in look exactly like the one that the patient had, 5 years prior to surgery.
So let me have that lead into the next question. You've talked about kinematic alignment, and I believe if we've talked a little bit previously, you've started using a medial pivot design implant within the last year. For the really nerdy knee guys and surgeons listening to this, like myself, tell me about that and your experience with that, and what does that kinematic alignment mean for you? What are you shooting for with that?
So I've kind of done the whole gamut. I did CR. That was how I trained with the board. And the problem with CR, sometimes it's hard to balance that PCL. And then 6 weeks out, or 3 months out, or a year out, they pop the PCL. So now they got some flexion instability. And I find that a challenge, and nobody wants to have a repeat operation. So I always find it somewhat challenging to balance that, particularly with mechanical alignment as this overarching convention that we've always said that's the right answer, right? So as more and more of those cases went by, I went to a CS, we get substituting, deep dish type of polyethylene, and that worked fairly well, but still, with a bad varus knee, now suddenly I need, especially with mechanical alignment, I'm taking a ton of lateral tibia, and that makes matters even worse for stability. And then you're doing multiple releases, which makes the legs swell. You get fracture blisters. They don't get the motion. So again, I wasn't happy with that. So I went down, one of the people I operated with was Lester Board, Lowry Barnes. And, Lowry has developed a medial pivot. He had a lot of thoughts in this space. And, I really wasn't quite catching what he was telling me at the time. And, but as more and more data is coming out, I figured I would try it. And so I do use a medial pivot knee now. I love the anterior posterior stability. It's shocking how there's very little anterior posterior shock. It's almost like you return an ACL to the knee, and that's what amazes me using a medial pivot design. Again, the only one I've used is Medacta. Using this design, I'm shocked at how quickly patients are able to recover stairs. I'm seeing some patients at 2 weeks doing reciprocal stairs, which I never saw, even with a TS knee, even with a CR knee. They weren't doing reciprocal stairs at 2 weeks. Up. Going down, I'm seeing that 2 to 3 weeks at best with a medial pivot. But going down was 3 months with a posterior stabilized knee. So I really think that the medial pivot allows, at least the design, that the one I'm currently using, again, I can't speak for all of them, allows an amazing amount of anterior posterior stability. And, a lot of patients complain about that anterior knee pain, and we think it's due to this clunk. I just don't think we're tensioning the anterior compartment well, except in this design, I'm seeing much better tension. There's less of that anterior posterior play of the tibia. And so they don't have to fire the quad through the entire arc of going up the stairs. Maybe I'm wrong. Again, some of these guys are way brighter than me. You can see analysis, may be able to say, no, Wickline, you're totally wrong. But what I can tell you clinically, 2 weeks, reciprocal gait pattern at 2 weeks, for a contractor who needs to be able to go up and down stairs to assess the job. He's not ready to do it yet, but he wants to at least start, making a plan for that new bathroom remodel at his next site. He can do it in 2 weeks. That's pretty impressive. Do you have that with your knees? I'm just curious.
Yeah, and I think that sort of the overarching concepts you're speaking to are exactly what you said before, which is that happy knee is one that extends and flexes easily, but has a great deal of stability. It's that goal of ligament isometry, and I really, honestly, I believe that whether it's custom implants or robotics or kinematic alignment or really any of these things are driven by that stability, by the ligament
Correct.
isometry, where we're not having condylar lift off, where we have very smooth contact throughout that range of motion, and it's not tensioning the soft tissues in an aberrant way when people walk or stair climb or things like that.
Mm-hmm.
I think we're trying to be the least wrong, if you will, as far as...
Yeah, exactly. I would agree with that, yeah.
So, great thoughts on that, and I appreciate you sharing that. You've had some publications about knee replacement and hip replacement in 10 pills or less, opioid sparing surgery. Direct this to patients and to the medical community and everybody. Why would we want to do that? And tell me about that.
Well, if you're an employer or a commercial payer or CMS, there's data out there, I think it's the CAST-LIGHT, CST, showing that the typical commercial payer patient costs them about $10,000 a year. So, if their premium is $17,000 for the year, they're making a $7,000 profit on that person that they can then use to an outlier, right? Where if you're an opioid addicted patient, you cost $19,000 plus, so almost double the cost, and now you lose money on that patient. So first of all, opioid addiction has a direct cost to insurers and to employers, as well as to that personal family that now has to deal with this problem, and whether or not that person loses their job ultimately. So opioid addiction it's for real. So I realize that the pandemic has killed any press on this, but it is a real problem in every community in the country. Do you agree?
100%. And clarify that too. When we talk about opioid addiction, I think there's I'm struggling for the right way to say this, but there's sort of a real pejorative around that, or the context is I have patients say to me, well, I'm not a dope head, but I need this, I'm hurting. And so we're talking, and correct me if I'm wrong, we're talking about patients that, require narcotics chronically, that have been on mm-hmm. narcotic medications for months and years.
Yeah, exactly. So, and there's so many different factoids that are out there. One fact that I see frequently in the meetings is, a 24-hour prescription of opioids taken, around the clock, it has up to a 6% risk of permanent addiction. 10-day supply can lead to up to a 20% risk of permanent addiction. And there's multiple studies showing that, many practices across the country, 50 pills, 60, 90, 156. I mean, that's a crazy number of opioids. And so what we have to do is patients need to understand, let me go back a step. The real answer to keeping patients off of opioids is, of course, setting up a whole program, an education program. I think that's the number one. And my paper talks about how to do that and what is involved for hips or for knees. And then number two, that education, that booklet, you have to explain to the patient when they're going to have pain, why they're having pain, and what to do to control the pain without opioids first, and then, use the opioids. So, for example, after I tell patients there's 3 periods that they might need an opioid. At 36 to 48 hours in the slowing peaks after their initial surgery, they're going to have increased pain most likely. The block inside the knee is wearing off. I use a pain ball currently, and so I tell them turn the pain ball up, back off on the exercises for 2 hours. Still having pain? Maybe try gabapentin. Still having pain? Okay, turn the pain ball up one more time, and maybe take a tramadol. So that's number one. So by noon on post-op day 2, the patient is usually they've gotten over that hump. But if they know it's coming, and they know that this is all going to get better by noon the next day, most patients won't take a pill because they know I explained to them what's going to happen. Then I tell the patient the next spike is going to be when the pain ball wears off. Between 3 and 5 days, you're going to have a 6-hour window when that pain ball wears off. Again, same thing, back off on the exercises, ice and elevate, maybe take a gabapentin. and then again, starting pain, maybe take a tramadol. And in between day 7 and 10 in our data, we saw that patients would suddenly have about 10% of patients have this day that suddenly they can't even explain what happened. They're losing their mind. It hurts. Okay, back off. Try gabapentin, try tramadol. And then randomly at 3 weeks after surgery, many patients who never used a single pill, they can't sleep. So they'll use a pill to sleep. And I don't think that's a great option for trying to sleep. So we try to tell patients that if there are other options, let us know if you're having trouble and so forth. So if you explain when you're going to have trouble and why, and it's amazing. Patients will say, this book is spot on, doc. How did you know I was going to feel this way? It's because as a surgeon, you just ask. You've heard this a million times. You know exactly what the patient's going to say when they come in at their 3-week visit and their 6-week visit. And it's the same questions every time because you and I have seen it. It's N of 10,000 for us. For that patient, it's N of 1 and they're scared. So you've got to control that anxiety.
I think your willingness to listen to that and to appreciate that and document and educate on that is really profound. Those are remarkable insights around that, and I think you've put it together in a good way. Let me shift gears totally here on you because we always want to throw in something controversial or semi-controversial. I had the chance to interview Dr. Leo Whiteside last week. Anterior approaches are terrible, apparently, and we should only be doing posterior approaches for hips, and he has a lot of strong thoughts on that. How about you?
Well, I trained posterior in Albany, and I also got to put a lot of hips back in. But at the time, that's 20 plus years ago. So, things have definitely improved in our techniques since that time. So, and that was the way to go versus anterolateral versus direct lateral. And then I did my fellowship with direct lateral with Lester, and didn't have to put any hips back in. So, my fellowship year compared to my 5 previous years, I was impressed that I never had to go to the ER. However, the abductor lymph, which the posterior guys complain about, it's for real. It definitely happens. Not everybody, but a fair number of patients. And so, that's a negative. I did a fair number of 2 incisions. We actually had pretty good success with it, but the literature was, came out against it strongly after a period of time. So I abandoned it because I was afraid of, getting sued, just based on the literature, despite having good results. The last, anterolateral, I didn't really do a lot of anterolateral. I did some in residency. And so, a friend of mine reached out to me and said, do you know anything about the anterior hip? I didn't, even though Dana Mears was at Albany at the time, working on this approach. And, I spent 3.5 years going to labs, thinking about it, looking at the cost of a special table. And I finally took the plunge, and, I wasn't sure. I had some successes, patients going home same day, next day. At the time in 2008, that was something to write about. But I wasn't really sure. What proved to me that it was better was my X-ray tech came to me after about 2 months doing anterior hip and said, Andrew, what are you doing differently for your patients? They can all get on, because at the time we took X-rays laying down. They can all get on and off the X-ray table with no problem at all. And I'd never seen this before. And, so that's when I knew I had something. I just need to keep refining it. So I respectfully disagree with my very esteemed colleague, Dr. Whiteside. I'm never going to hit his numbers and so forth, but I have a bad hip. I'm having an anterior approach all day long. He may be right. There's some people that if they didn't train doing it, they're not good at it. But that can be for anything. I mean, I'm terrible at distal humerus fractures. Do not sign up on my schedule for distal humerus fractures. I agree. So I think you have to do what you're good at.
I think that's exactly right, and that's a great way to say that. What are your projects right now? What are you working on? What do you see coming down the pipe?
Well, a couple of different things. One is I'm really working on a CAT-based program. I just did a lady from Pakistan, did a gentleman that was referred to me from Australia, did a guy, like I said, just drove up from North Carolina. You know, cash pay makes the most sense to me, and I like value. I have a very transparent website. Here's the cost, and here's my value. Every total knee gets iovera. That's a cryoablation. I've had that myself. It works. We saw in our data outside of the studies I published, we saw 33% reduction in pain scores when you add the iovera to my protocol. Some patients 50%. So on day 2, there would be a 6 as my average number. They would either be a 3 or a 4. I find that the iovera cryoablation is very helpful, but it's not super strong for that first 3 or 4 days. I think you need something else. You need a adductor canal block of some sort. The pain ball or the Exparels of the world, those things give you great relief, like a marathon runner for the first 3 days. And after that, they're done, right? Or not a marathon runner, but a sprint, right? The cryoablation is like the marathon runner. It's not super fast out of the gate, but week after week, month after month, that patient has good pain relief, and I think it helps them do better, see better with back to work. So, my cash pay program, every patient gets that because I believe in it and I think it makes sense. And I don't have to fight with the insurance company to get it covered. I've got a big insurer here in town that used to cover it. Now currently they're not covering it because Wickline, you're already at the lowest opioid in the nation. Why should we cover this? Because 0 opioids would be great, and when you want your mom to have the least amount of pain after an otherwise painful surgery, then that's why we should cover it. And by the way, my 90-day cost is $17.8, for cash pay. That beats anyone else in your market. So that's why you should cover. You can work with me. But that's a project right now. The big player in town wants to work with us to do a pilot program to show how we can have a lower cost overall, and then hopefully incentivize other surgeons. There's been, Matt, have you seen a pay increase for total knee or total hip in the last 20 years? I haven't. It's so that's really why I'm looking to cash pay. The patient and I having a personal interaction about what I can give them, what the value is, and I can get a reasonable reimbursement of $3,000. My surgery center makes money. The patient is happy because they got one of the lowest 90-day costs in the nation. So for them, out of their pocket, that's a great deal, right? And it's a win-win for everybody. And I really think that's what we should be doing. We should stop hiding behind these NDAs about what we pay and what we accept and so forth. It's not fair. Marty McCary's book is excellent on that. I don't know if you ever get a chance to read that, but I would recommend it.
I'll check that out. For everybody out there, patients, surgeons, anybody in the space that's interested and wants to find you, how do they get to Dr. Andrew Wickline?
So it's andrewwicklinemd.com. And like I said, if you're a cash pay patient, self-pay patient, we have the lowest complication rate in New York at 1.6%. That's my hospital. My personal is 1.2%. We have lowest opioid use published in the nation currently. Although I'm certain that many of my good colleagues are going to beat me. I'm going to have to try to work harder to get down to 0. And that's really I want to take care of you. If you're a patient that wants no nonsense from the insurance company and authorization, and you want personalized attention, come see us. I'm happy to do so.
That's great to hear, and I know a lot of people are going to want to reach out for that. Dr. Wickline, thanks so much for joining us. I've learned a lot just hearing from you, and love your thoughts about visiting other surgeons and learning. And if you're open to it, I've got to come to New York and hang out with you. I'm going to wait till it gets a little warmer and I get my second dose of COVID vaccine, and everything's good.
Well, I definitely want to do the same. I mean, like I said, it's always a two-way street. Whenever, like I said, I got a young surgeon coming out to visit me from Ohio, and I'm going to probably learn from him as much as I hope to show him what we're doing. There always has to be that give and take, and I'm thankful for all of the surgeons who might be listening to this that I visited in your OR. Doug Dennis, again, Lowry Barnes, and so forth. I really appreciate that they took time out of their. It's just a headache when you have a surgery in some ways, right? You're not going at your normal pace and you explaining things. So I'm very appreciative that the results I had is because of all of my colleagues, that were willing to let me operate. So I want to say thanks, and my team says thanks. So Matt, I want to come visit you. I'll come down now because we got about a foot of snow from this big nor'easter. Maybe I'll get out of here right now.
Anytime, we'll make it happen. So great conversation today with Dr. Andrew Wickline. This is a surgeon that clearly I share a lot of values with, and that cares deeply about his patients and is very deeply involved into examining his process and what he's doing. Fascinating to hear his insights about patient care, protocols for recovery and rehabilitation, and opioid-sparing surgery. I think this is huge in our world right now, and I'm looking forward to how these advancements continue to change things for us in the next couple of years. This is Matt Barber with the ORTHO REAL podcast. Thanks so much for joining us again.